continuation of drug therapy of bronchial asthma. In my previous episode, we have discussed the pathophysiology of bronchial asthma, classification of drugs that are used in the management of bronchial asthma, the details of bronchodilators. In this episode, today we will be discussing the mechanism of action, the clinical uses, adverse effects and contraindications of glucocorticoids, leukotriene pathway modulators, mast cell stabilizers, and monoclonal antibodies used in the management of bronchial asthma. Also, the management of status asthmaticus will be discussed. So, to start off with glucocorticoids. Glucocorticoids have minimal effect on acute bronchoconstriction. This is because they are poor bronchodilators and have a delayed onset of action. Therefore, they are not useful drugs for the management of acute attack of bronchial asthma. However, they are considered to be the most effective drug for the management of chronic bronchial asthma. Glucocorticoids treat nocturnal asthma, treats inflamed airways, and reduces nocturnal awakenings and improves the diurnal function of airways. They are indicated in the prophylactic treatment of asthma. They reduce the prevalence and severity of exercise-induced asthma. So how do glucocorticoids act? Glucocorticoids inhibit all kinds of inflammation. They reduce the production of cytokines and chemoattractant products and reduce inflammatory changes in the airways, which is a characteristic feature of chronic bronchial asthma. Therefore, inhaled glucocorticoids is considered to be the drug of choice in chronic bronchial asthma. So, what is the molecular mechanism of action of glucocorticoid that is responsible for anti-inflammatory actions? Glucocorticoid has the ability to penetrate the membrane and enter into the cytoplasm. It binds with the glucocorticoid receptor that resides in the cytoplasm and forms glucocorticoid receptor complex. The glucocorticoid receptor complex then translocates into the nucleus and causes transcription of genes that are responsible for the formation of inflammatory proteins. The transcription of inflammatory proteins requires acetylation of histones, which occurs in presence of histone acetylase enzyme. So, glucocorticoids have the property to inhibit histone acetylase enzyme, thereby inhibiting acetylation of histones, which is required for the transcription of inflammatory proteins. So, this suppresses the synthesis of inflammatory proteins and causes recruitment of histone deacetylase and the synthesis of anti-inflammatory proteins. So, increased synthesis of inflammatory proteins such as interleukin 2, 3, 4, 5, interleukin 13, granulocyte monocyte colony stimulating factor, tumor necrosis factor is responsible for anti-inflammatory actions. Also, there is increased synthesis of anti-inflammatory proteins such as interleukin 10, which produces a number of anti-inflammatory actions. In this way, glucocorticoids inhibit all kinds of inflammation and reduce bronchial hyperresponsiveness, bronchial mucus secretion, vasogenic edema, and recruitment of inflammatory cells and other inflammatory changes in the airways. Therefore, it is considered to be the drug of choice in chronic bronchial asthma, where inflammation plays an integral role. Glucocorticoids reduce the frequency of asthma exacerbations, prevents further asthma attacks, and helps to improve the quality of life of the individual. So, how do we classify steroids that are used in the management of bronchial asthma? The steroids can be classified based on the route of administration as oral steroids, parenteral steroids, and inhaled steroids. Prednisone, prednisolone, and methylprednisolone are examples of oral steroids. Parenteral steroids are hydrocortisone and methylprednisolone. Some of the examples of inhaled steroids are beclomethasone, budesonide, flunisolide, fluticasone, triamcinolone, mometasone. The inhaled steroids are widely used in the management of bronchial asthma. The advantages of inhaled steroids are: 1. The inhaled steroids are directly delivered into the airways, achieving an adequate target concentration at low dose. Therefore, at a very low dose, an effective therapeutic benefit can be obtained, and this reduces the risk of side effects because of lesser dose. Secondly, the inhaled steroids are structurally modified to enhance topical absorption of the drug. This reduces the amount of drug entering the systemic circulation and reducing the incidence of systemic side effects. Thirdly, the side effect profile of inhaled steroids is better than oral steroids. Oral steroids, when used for a shorter period of 7 to 10 days, do not cause any serious side effects. However, when used for a prolonged period, can cause harmful effects on the body such as rise in blood pressure, hyperglycemia, weight gain, osteoporosis, muscle weakness, fatigue, cataract, glaucoma. Also, when exogenous glucocorticoids when used for a long period can cause suppression of hypothalamic pituitary axis. Therefore, caution must be considered during withdrawal of glucocorticoids because sudden discontinuation of steroids can cause acute adrenocortical insufficiency which can be life-threatening. Therefore, some of the measures to reduce hypothalamic pituitary axis suppression are: firstly, the use of shorter duration glucocorticoids cause lesser hypothalamic pituitary axis suppression than longer acting glucocorticoids. Shorter acting glucocorticoids such as prednisolone is used that reduces the hypothalamic pituitary axis suppression. Secondly, single dose administration of steroid in the morning reduces the suppression of hypothalamic pituitary axis. This is because it mimics the diurnal rise in cortisol levels in the body. Thirdly, alternate day regimen of steroid therapy is preferred because it reduces the suppression of hypothalamic pituitary axis. Although inhaled steroids are commonly used in the management of chronic bronchial asthma, they may not be effective in severe asthma because the airways are constricted, thus preventing the drug from reaching the peripheral sites. Therefore, oral steroids such as prednisolone and methylprednisolone are preferred steroids in the management of these cases. Parenteral steroids such as hydrocortisone and methylprednisolone are used in the management of acute severe asthma as the dose can be adjusted as per the needs. So what are the side effects expected with the use of inhaled steroids? Inhaled steroids can get deposited in the mouth and cause suppression of local immunity. This makes the person prone to infections such as oropharyngeal candidiasis. Also, inhaled steroids can get deposited in the larynx, causing hoarseness of voice. So, to prevent oropharyngeal candidiasis, the patient is instructed to rinse the mouth each time after using the inhaler. So, this decreases the incidence of oropharyngeal candidiasis. Also, the patient is advised to use a large volume spacer. The large volume spacer would capture the large droplets that would get deposited in the larynx, causing hoarseness of voice. So these side effects can be minimized by giving the instructions and educating the patients on the use of inhaled steroids. So the next question is, although a significant proportion of the steroid gets deposited in the mouth and can be swallowed, systemic side effects are less likely. The reasons are: 1. The inhaled steroids are structurally modified so that the topical absorption or absorption through the pulmonary epithelium occurs rapidly and very less drug reaches the systemic circulation, causing systemic side effects. Secondly, inhaled steroids such as beclomethasone, fluticasone have high first-pass metabolism. So, they are destroyed in the liver before reaching the systemic circulation, decreasing the oral bioavailability of the drug and decreasing the side effects. Thirdly, drugs such as cyclisonide and beclomethasone are prodrugs or inactive drugs when taken orally, but they undergo activation in the lungs and therefore the effects or the therapeutic effects or benefits are confined to the lungs and the side effects are less. So these are the following measures that are taken to reduce the incidence of side effects. In addition, glucocorticoids cause upregulation or supersensitivity of beta-adrenergic receptors, and this increases the receptor responses. In this way, glucocorticoids potentiate the effects of beta-adrenergic agonists. Therefore, inhaled corticosteroids are combined with beta-adrenergic agonists to potentiate the effects of beta-adrenergic agonists in the management of chronic bronchial asthma. The next class of drug is leukotriene pathway modulators. The leukotrienes play a central role in the pathogenesis of bronchial asthma. Leukotriene C4, D4, E4 are 1000 times more potent than histamine in causing bronchoconstriction and inflammatory changes in the bronchial airways. Therefore, drugs are developed to reduce the synthesis of leukotrienes and to antagonize the leukotriene receptors, thus inhibiting the leukotriene-mediated changes in the bronchial airways. So let us now understand the leukotriene pathway and the effects of leukotriene pathway modulators. In the figure, as we can see, arachidonic acid that is synthesized from phospholipids, which subsequently forms prostaglandins in presence of cyclooxygenase enzyme and leukotrienes in presence of 5-lipoxygenase enzyme. Leukotriene C4, D4, E4 causes acute bronchoconstriction, increased bronchial mucus secretion, increases bronchial hyperreactivity or hyperresponsiveness, vasogenic edema, and inflammatory changes in the airways. Leukotriene B4 is a chemoattractant protein. It attracts the neutrophils, eosinophils, macrophages, and facilitates the inflammatory changes in the bronchial airways. Therefore, drugs such as Z-lutein inhibits the 5-lipoxygenase enzyme, thereby inhibiting the synthesis of leukotrienes and inhibiting the leukotriene-mediated changes. Leukotriene receptor antagonists such as zafirleucas, monteleucas, and tranleucas antagonize the leukotriene receptors and prevent leukotriene-mediated changes in the airways. Therefore, leukotriene synthesis inhibitors and leukotriene receptor antagonists prevent leukotriene-mediated changes and acts as an anti-inflammatory agents. Since they have anti-inflammatory actions, they can be used as an alternative to inhaled corticosteroids in the management of mild to moderate chronic asthma. However, in the treatment of moderate to severe chronic asthma, they can be used as an adjuvant to inhaled corticosteroids and beta-2 adrenergic agonists. But do remember that leukotriene pathway modulators are poor bronchodilators. Therefore, they are not suitable in acute attack of bronchial asthma. These drugs are useful in the prophylactic management of exercise-induced asthma. The leukotriene inhibitors have good oral absorption and are available as oral tablets. Therefore, when taken orally, they can be used for the treatment of coexisting allergic conditions such as hay fever, eczema, and allergic rhinitis. These drugs are highly effective in the treatment of NSAID-induced asthma. In terms of side effects, the leukotriene inhibitors have minimal side effects. Z-lutein has a shorter duration of action, therefore has to be given more frequently. This causes problems of compliance or adherence to therapy. Also, these drugs can cause a rise in the liver enzymes and potential hepatotoxicity, which is very rare. Zafirleucas, monteleucas can cause eosinophilia and vasculitis in certain patients. The next class of drug is mast cell stabilizers. The mast cell stabilizers stabilize the mast cells and prevent the release of histamine and other inflammatory mediators. These reduce the inflammatory mediated changes in the airways and help in the management of bronchial asthma. So mast cell stabilizers can help in the prophylactic treatment of bronchial asthma and in exercise-induced asthma. The next class of drug is monoclonal antibodies. The monoclonal antibodies include anti-IgE antibodies such as omalizumab and antibodies directed against interleukin-5 such as benralizumab and mepolizumab. Omalizumab is a monoclonal antibody that is directed against IgE antibody and prevents the binding of IgE to the IgE receptors and the release of inflammatory mediators from the mast cells and checks inflammation and treats bronchial asthma. Monoclonal antibodies such as mepolizumab, benralizumab act against interleukin-5 that is responsible for differentiation, proliferation, activation and migration of eosinophils into the airways and causing inflammation. So by acting against interleukin-5, it is very useful in the treatment and management of resistant eosinophilic asthma. The next is status asthmaticus. Status asthmaticus is also known as acute severe asthma or refractory type of asthma. This is usually precipitated by an acute respiratory tract infection. The attack is not easily terminated and can cause hypoxemia and acidosis. It is a fatal medical emergency and requires prompt treatment. The patient should be hospitalized and treatment should be initiated immediately. The general supportive measures are 1. Acidosis can be treated by sodium bicarbonate by IV route and dehydration can be treated by IV fluids. In terms of specific treatment, if the attack is not life-threatening, salbutamol can be administered by nebulization and repeated every 15 minutes. Oral prednisolone 30 to 60 mg or IV hydrocortisone 200 mg stat can be administered. Humidified oxygen 60% concentration or more can be given. If the attack is life-threatening, aminophylline 250 to 500 mg diluted in 10 to 20 ml of normal saline given by slow IV infusion over a period of 20 to 30 minutes. Hydrocortisone 200 mg IV stat and then subsequently followed by 100 mg. Antimicrobial agent can be given if there is evidence of infection. So these are the life-saving measures in the management of status asthmaticus.
This brings us to the end of the topic. These are my references. Thanks for watching. Please like, subscribe and share.